Hello, my name is Nada. I will present to you patient case of Vijay. She is 61 years old African American who presents to the ambulatory clinic for annual checkup. Vijay has recently urinary tract infection and yeast infection, and those resolved with levofloxacin and fluconazole. On her last visit, her metformin dose was increased to be 2 grams per day due to progression of her A1C. She hasn't reduced carbohydrate intake yet, but tried to decrease salt and cholesterol intake since her last visit last July, and she is willing to lose more weight. She denied any symptoms of dysuria. She addressed well tolerance to her medications with high adherence. Past medical history: she has obesity, postmenopausal metabolic syndrome, hypertension, dyslipidemia, diabetes mellitus, and osteoarthritis. Family history: mother died of heart attack at age of 62, father alive with type 2 diabetes mellitus. Social history: she's married for 33 years, former smoker, quit in 2003, doesn't drink alcohol, and walks 3 days a week, but limited by arthritis, knee pain recently. Medication and allergies: she is allergic to penicillin with anaphylaxis, and medication that she is taking are atorvastatin 80 mg once daily, metformin 1 gram twice daily, aspirin 81 mg once daily, and Tylenol 650 mg as needed for osteoarthritis pain. High priority problems are diabetes mellitus, hypertension, and dyslipidemia. Moderate priority problem, obesity. Low priority problems are osteoarthritis and postmenopausal. For the assessment of the disease, first the patient has 3 main diseases, and I will go through assessment for them. First, I will start with hypertension. Vijay is experiencing uncontrolled stage 2 hypertension as evidenced by her current blood pressure 144 over 88 and 146 over 87 mmHg when repeated. The new classification of hypertension stakes appear in Table 6 and Figure 4 in the ACC-AHA guideline. She reported similar blood pressure measurement at home despite the effort to reduce salt intake and exercising. Secondary causes of hypertension were ruled out, and these confirm the diagnosis of primary hypertension. Contributing factors are age, female gender, lifestyle, race, and being overweight. Goals of therapy are to reduce patient blood pressure and reduce associated morbidity and mortality from cardiovascular events. Assessment of current drug therapy: Vijay hasn't started any treatment or medication for hypertension to be assessed. However, she is a candidate for the treatment by the guideline. Recommendation regarding hypertension: initiate chlorthalidone 12.5 once daily, then titrated after 2 weeks to be 25 mg once daily. If the patient blood pressure is still over the target, which is 130 over 80 by the ACC-AHA 2017 guidelines. Also recommend continuing pharmacotherapy, non-pharmacotherapy like DASH diet, exercising 150 minutes per week, and achieving more weight loss. The rationale behind those: per the new ACC-AHA 2017 guideline, section 9.6, patients with hypertension and diabetes mellitus should start hypertension treatment if blood pressure is 130 over 80 or more. This class 1 level of evidence B. Although the patient is classified as stage 2 according to the new 2017 AACC guideline, her blood pressure isn't elevated by 20/10 or more than the recommended target, which is, as I said, 130/80. So in this case, treatment with one antihypertensive agent is reasonable. Section 10.1.1 in the ACC/AHA guideline shows that Black patients tend to have greater antihypertension effects with calcium channel blocker and thiazide, making them ideal first-line monotherapy or as initial agents in multiple drug therapy. A trial called ALL-HAT supports that thiazide diuretics such as chlorthalidone should be the first option or the first-line therapy in treating hypertension. It exhibits chlorthalidone superiority in preventing cardiovascular events in hypertensive patients compared to calcium channel blocker and ACE inhibitors. Lisinopril 40 mg recommended by the primary care physician or provider is not suitable for BJ given her race. For monitoring for chlorthalidone, we will monitor efficacy through maintenance and improvement in blood pressure and urine output. Safety, serum and urine electrolytes, uric acid, blood glucose, renal and liver functions. For the assessment of dyslipidemia, BJ has uncontrolled dyslipidemia based on her recent fast and panel with total cholesterol of 227, low density lipoprotein 105, and triglyceride level of 210. The patient BJ has a 10-year atherosclerotic cardiovascular risk factor of 19.6, which is considered high. Contributing factors are age, race, family history of cardiovascular, obesity, abdominal obesity, and lifestyle habit. Also, she has high HSCRP, which is measured as 2.2 milligram per deciliter. Goals of therapy: reduction in non-high density lipoprotein cholesterol and preventing atherosclerotic cardiovascular events. Assessment of current therapy: BJ is taking atorvastatin 80 mg, which is a high-intensity statin. The high-intensity statin expected reduction in low-density lipoprotein is 50% or more. However, BJ LDL reduced by almost 38% in 3 years. So another cholesterol-lowering medication may be needed. So for the recommendation, I recommend continuing taking atorvastatin 80 mg once daily and start estimate 10 mg once daily. Continue taking aspirin 81 mg once daily, and of course continue the non-pharmacological therapy. The rationale behind those: the patient's ASCVD risk is 19.6 and she's a diabetic with low density lipoprotein level 105, and this is higher for her should be 70. So she is still a candidate for high intensity statin. Recommendation number 68 in the AACE 2017 guideline shows that estimab can be used in combination with statin for further reduction in both low density lipoprotein cholesterol and in the atherosclerotic cardiovascular events risk. This comes as a grade A level of evidence 1. Also, there is a control or randomized control trial shows that using estimab with a statin in combination has an incremental reduction in low density lipoprotein cholesterol, uh, about 15% beyond statin alone. Another randomized controlled trial supports the effectiveness of estimab as addition to statin in reducing LDL cholesterol by additional 25.8% in total population compared to 2.7 in statin-only arm. It also exhibits a reduction in other lipid parameters and in HSCRP. Regarding aspirin, per the United USPSTF, the decision for initiating low dose of aspirin in patients 60 to 69 years old who have 10 years risk factor uh, or more than 10%. This decision is individualized one, and since the patient is already taking aspirin 81 milligram for primary prevention of atherosclerotic cardiovascular events, continuation is reasonable. In a study done in Italy, aspirin low dose, uh, about 100 milligram once daily, seems to be effective for primary prevention of ASCVD and inflammatory marker reduction, such as HSCRP in patients with type 2 diabetes mellitus and hypertension. Non-pharmacological therapies are recommended by both ACC AHA 2017 guideline for controlling hypertension and AACE for dyslipidemia to reduce cardiovascular events. It provides almost 20 to 30 milligram mmHg reduction in the systolic pressure, and this appears in the table 15 in 2017 guideline. Monitoring for estimate will monitor efficacy by checking lipid panel at the baseline and periodically, and for safety we will check liver function, arthralgia, fatigue, diarrhea, and upper respiratory infection. Regarding the diabetes mellitus, for assessment of diabetes mellitus, BJ has uncontrolled diabetes mellitus as evidenced by her current A1C 7.6 and fasting blood glucose level, which is 157 mg per deciliter. She still hasn't started a low carbohydrate diet, which is considered a contributing factor of having uncontrolled diabetes mellitus. Other contributing factors compose age, family history, being overweight, and lifestyle. Since she's still consuming diet that include carbohydrates. Goal of therapy to control her diabetes mellitus with A1C level of 6.5 or less as per ACE 2015 diabetes guideline, prevent micro and macro vascular complications, enhance quality of life, and reduce mortality. For the assessment of current therapy, besides the lifestyle modification, the patient is taking metformin 1 gram twice daily, which is appropriate. However, she hasn't achieved the goal of therapy, as still her blood sugar and A1C are high. Therapy should be optimized, and a second agent should be initiated as recommended by the guideline. So for the recommendation, I recommend starting Genovia 100 milligram once daily, continue metformin 1 gram twice daily. Rationale behind that, recommendation number 17 in the AACE guidelines for diabetes shows that using Genovia, which is a DPP-4 agent with metformin, is recommended in patients have A1C 7.5 or more, and this comes with a grade C level of evidence 3. So I looked for a primary literature to support using Genovia. I found a study by Williams Herman et al. That displays that a significant reduction in A1C from baseline reached 1.7%, and this has been observed in group taking metformin 1 gram twice daily and Genovia sitagliptin at 100 milligram once daily. For monitoring Genovia efficacy, we will monitor A1C twice per year if the patient demonstrates a stable glycemic control and meets the treatment goal, or doing that 4 times per year if she doesn't meet the goal. For safety, we will monitor serum glucose, hypoglycemia, renal function, and symptoms of heart failure. Some other side effects include headache, nasopharyngitis, arthralgia, angioedema, and pancreatitis. So regarding the patient education for all the three diseases, we would want to encourage the patient to achieve more weight loss and try reducing her body mass index to be 24.9 or less, and reduce her waist circumference to be 35 or less. The patient should be aware of signs of heart problems from Genovia, such as cough, shortness of breath, abnormal heartbeats. Also signs of hypoglycemia, including shaking, dizziness, tiredness, feeling, headache, feeling weak, confusion, hunger, sweating, and fast heartbeats. Patients should be screened for any diabetes complications such as retinopathy, neuropathy, and nephropathy. Encourage BJ to eat healthy through restricting carbohydrates, added sugar, and foods that containing cholesterol, and encourage to consume more vegetables and fruits. Discuss with BJ her desire to perform self-monitoring blood glucose testing, since she doesn't want to uh, have medication through or any injection for treatment, and she may be not ready to do self-monitoring blood glucose. Adherence to new medications is important, as well as adherence to other medications already have been taken. Vaccination for such as a flu vaccine, in case that the patient still hasn't gotten that. Follow up, we will want the patient to follow up within 4 weeks to evaluate her response to medication. Thank you.